welcome to the first in a series of webinars focused on COVID-19. In light of the healthcare pandemic, we thought it was important to start the series with medical experts, those who are working with those on the front line. So without further ado, allow me to introduce Alphonso David, President of the Human Rights Campaign.
Thank you very much. I don't know if you can see me or hear me. Let me know that you can.
We can hear and see you.
Great. Good afternoon, everyone. Thank you so much for joining us. As all of you know, we are facing a pandemic, a crisis that is affecting the LGBTQ community and also affecting people living with HIV. People around the world are grappling with the impact of COVID-19 and what impact it's having on their daily lives, and is particularly distressing for communities who are at greater risk. People living with HIV are uniquely impacted by this pandemic, and research suggests that those with certain chronic medical conditions are at an increased risk of serious illnesses associated with COVID-19. People with HIV are more likely to possess these conditions, which include older age, cardiovascular and chronic lung disease, and immune suppression. This will have a greater impact on Black and Latinx communities, according to the Centers for Disease Control. 1 in 2 Black cisgender men who have sex with men and 1 in 4 Latinx cisgender men who have sex with men will be diagnosed with HIV in their lifetimes. Today, 1 in 2 Black transgender women and 1 in 4 Latinx transgender women live with HIV. The experts participating in today's webinar will discuss how this pandemic will impact people living with HIV. But what remains clear is that for us to get through this crisis, we must do it together, just like we've done it before when we faced other crises. At the Human Rights Campaign, our top priority is the well-being of the LGBTQ community. As we have navigated an ever-changing landscape, we have and will continue to take steps to protect and inform our communities and advance our work, which is more important now than ever before. Together, we know that we can overcome these challenges. And I want to make sure that you know that we are here to make sure that we represent the community and we provide resources and support and work with all of our colleagues in every single state and also outside of the United States. I want to thank Jay Maurice and others for organizing this event. And with that, I will turn it back over to Jay Maurice.
Thank you, Alphonso. At this moment, I'd like to introduce our moderator for the discussion, my co-moderator, my colleague, Ms. Andrea Lavario. You're on mute, Andrea.
Good afternoon, everyone, and thank you for joining our webinar today. I am very happy to be able to introduce our panel of experts who've joined us. I'll start off with Dr. David Hardy. Dr. Hardy serves as an adjunct professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. He served as a senior director of the research department at Whitman Walker Health in Washington, D.C. Dr. Hardy received his medical degree from Baylor College of Medicine and completed his residency in internal medicine at Harbor UCLA Medical Center. He has cared for persons with HIV since 1982 and conducted research on HIV and related diseases since 1984. Dr. Hardy currently serves as the immediate past chair of the board of directors of the HIV Medicine Association and as the chair of the education committee of the American Academy of HIV Medicine. Emily McCloskey is the Director of Policy and Legislative Affairs at NASTAD, the National Alliance of State and Territorial AIDS Directors. Since joining NASTAD in 2011, she has represented state HIV and hepatitis programs to Congress, federal government and partners, and national and community stakeholders, as well as NASTAD's Ryan White program and appropriations policy work. Emily co-chairs the Federal AIDS Policy Partnerships AIDS Budget and Appropriations Coalition, a coalition of national advocates and organizations dedicated to increasing federal resources for HIV, viral hepatitis, and STD education, prevention, treatment, and care. In addition, she co-chairs the Ryan White Working Group, leading the HIV community's discussions on the Ryan White reauthorization. She received her Bachelor's of Arts in Politics and Media and Communication Studies from Ursinus College. Next, we have Tim Horn. Tim is the Director of Healthcare of the Healthcare Access Team and oversees NASTAD's Medication Access and Pricing portfolio. He works across teams to ensure fair pricing and equitable access to drugs and biologics critical to the prevention and care needs of people living with and vulnerable to HIV and hepatitis C virus, HCV. In addition to coordinating the ADAP Crisis Task Force, Tim provides technical assistance to city and state health departments to address inpatient and outpatient medication access challenges and works in close collaboration with NASTAD's policy team and its partners to address the need for prescription drug cost containment. Dr. Darrin Johnson is currently the Executive Director at BU Wellness Network, an HIV service organization in Indianapolis, Indiana. Dr. Johnson is a graduate of North Carolina A&T State University with a BS in Mass Communications, holds a master's degree in public administration from the Keller Graduate School, and a PhD in health sciences research from the University of North Carolina at Charlotte. He has 13 years of experience working in community engagement, HIV prevention, and research. This includes positions as project coordinator and education department manager at Metrolina AIDS Project, senior prevention coordinator at the Carolinas Care Partnership, as well as research director and professor of program evaluation in the School of Social Work at UNCC. Additionally, Dr. Johnson is a co-chair of the Marion County Ending the Epidemic Task Force, a faculty member for the Community Health Improvement Initiative, a leader of Black Treatment Advocates Network, Indiana, and an active member of He Sigma alumni chapter of the Phi Beta Sigma fraternity. Scott Schoettes lives openly with HIV and is counsel and HIV project director at Lambda Legal. Scott litigates impact cases involving discriminatory actions based on a person's HIV status and authors amicus, or friend of the court briefs, on issues of import to people living with HIV. His policy portfolio includes HIV criminalization and the blood donation ban, and he served on the President's Advisory Council on HIV and AIDS, PACHA, from 2014 to 2017. Welcome to our panel, and thank you all for joining us today. Back to you, Maurice. You're on mute.
Sorry. So thank you for that, Andrea. So what we're going to do now is we're going to go into our individual breakouts, or not breakouts, but the presentations. So we could advance to the next slide. And first up is Dr. David Hart.
Thank you very much, Jay Maurice and Andrea, and for that great introduction, Alphonso, David. It's great to hear that HRC is really stepping up to get this information out in a time and place where it's really needed, based upon the newness of everything that's happening. And every day we hear the word unprecedented. I'm going to quickly go through a capsulization of the recent Department of Health and Human Services interim guidance for COVID-19 and persons living with HIV. Next slide. This slide is basically, I wanted to put out there first, just to remind us all of who are the persons that have been identified from the epidemic as it began in China and throughout its different manifestations around the globe, about those who are at highest risk of life-threatening COVID-19. Those are individuals who are 60 years of age and older, those who have diabetes mellitus, regular diabetes, high blood pressure, heart disease, and of course, lung disease as well. Keeping that in mind, next slide. The interim guidance really, I think, hones in on some very important questions, particularly for persons living with HIV. and basically states that the disease course of COVID-19 in persons with HIV does not differ from that in persons without HIV. But of course, this is based upon very limited data to date. And of course, it is not yet known whether advanced HIV infection, meaning a CD4 T cell count below 200, is a risk factor for complications of COVID-19. Oftentimes, immune deficiency caused by HIV has been characterized or measured by a CD4 cell count less than 200, which of course is also a definition for a CDC definition of AIDS. It's also important to realize that comorbidities such as heart or lung disease, which can be more common in persons with HIV at any given age, does increase the risk for more severe course of disease, as we spoke about before. And this includes chronic smoking, which is a very important thing because we know that about twice as many people with HIV than those who do not have HIV are smokers. And until more is known, additional caution for all persons with HIV, especially those with advanced HIV or poorly controlled HIV, is really warranted. I'm not going to say too much more about that, but I think it's important to just recognize that one of the most important things during this epidemic is to maintain a supply of ART and all other concomitant medications that a person takes, to have an influenza or pneumococcal vaccination if you haven't had one yet, because these are more common than COVID-19 are in general, and they can actually complicate and make COVID-19 even worse if they do occur, and they are preventable by vaccination. And also make sure that persons with HIV are aware of all the CDC recommendations, such as social distancing, proper hand hygiene, etc. Next slide. So basically, persons with HIV should basically, again, maintain at least a 30-day supply of medications and ideally a 90-day supply of medications. Consider switching to mail order delivery if that is possible, because it may provide a more reliable way of getting the medications, and 90 days are usually given in those situations. And if a regimen switch and antiretroviral therapy is planned, then it's probably a better idea to delay that than trying to do it right now if the situation can be continued as it is now in terms of medications. The comments about lopinavir, ritonavir, or the medication commonly known as Kaletra, is that it has been used in some off-label treatment, meaning it is not specifically known to work against COVID-19 virus, but clinical trials are underway. It is also important to understand that a small open label study in China found that there was no difference between 14 days of Kaletra versus no Kaletra, only standard of care, in terms of time to clinical improvement or death. So far, one small study from China is showing that Kaletra does not work, but there are other larger studies going on around the globe. Next slide. It is important, I think, also to keep in mind that clinical laboratory monitoring visits for persons who are HIV positive should continue to happen if they are needed. Routine appointments should probably not be done in person, but through telephone or virtual visits in order to try to decrease exposure to the virus in public areas. But just remember that it is important to keep up with the connections with your healthcare providers. You may be able to put off blood drawing at this point in time, especially if your T cells and viral load have been stable, but stay in contact with your providers in terms of telephone or virtual visits. For persons with HIV and who are in opioid treatment programs, it's very important to be able to keep that medication flow going. And so make sure that you're staying in touch with your provider who provides you with the opioid treatment program, and use the methadone or other medications that you have gotten as you normally would. Next slide. So the last thing is if a person with HIV is hospitalized, if you or someone you know are hospitalized, and you should definitely continue the same antiretroviral therapy. Do not stop the medication, because that is what is keeping the HIV at bay and suppressed. There are specific information about certain medications like ibalizumab, Trogarzo, which is given by intravenous medication, which has to be specially ordered for the patient through the hospital. If anyone is on an investigational antiretroviral medications, those should be taken to the hospital for the person because oftentimes they're not available through a hospital pharmacy. Try to avoid any kind of substitutions of medications during the hospitalization, except for when the DHS recommendations on antiretroviral drugs say that those can be switched easily without problems. And of course, if there are critically ill persons who are requiring feeding tubes, then there are some antiretroviral medications which are available in liquid form, but many pills, but not all, can be crushed and given that way. But this can be done by consulting the HIV specialist or pharmacist in the hospital. Next slide. This is my last slide. It's important because this may be occurring that when receiving an investigation or off-label treatment for COVID-19, that there's an important to make sure that that treatment does not interfere with the ongoing anti-HIV medications, because drug-to-drug interactions can be very possible. We know that medications such as Kaletra are being studied, which is an HIV medication and has many drug-drug interactions, so important to make sure that if that is given as part of a clinical trial or clinical practice, that the drug-to-drug interactions with the ongoing HIV medications are carefully monitored. The same thing with the hydroxychloroquine or the azithromycin that are being used to make sure that drug-drug interactions are not being problematic there. Because there is a possibility that persons with HIV who are on stable medication could certainly be enrolled in some of these clinical trials. If you're interested in what is going on, certainly the best source of knowing about clinical trials for COVID-19 is the clintrials.gov website. I actually found about 86 of them recently when I looked. I'm going to end there and just be available for questions as we continue our webinar. Thank you.
Thank you so much, Dr. Hardy. Next, we have Tim Horn and Emily.
Great, thank you, Jay Maurice, and good afternoon, everyone. So I'll be talking about prescription drug access in these very fast-moving and dynamic times, and my colleague Emily will walk us through some of the ways our state HIV programs, including AIDS drug assistance programs, are thinking about COVID-19 and responding to the needs of people living with HIV. So first slide, please. All right, so first I wanted to speak generally about prescription drug access and the need to keep a close eye on key players along global, domestic, and regional supply chains in an epidemic that is proving profound in its impact globally, domestically, and regionally. So many generic drugs, for example, depend on active pharmaceutical ingredients that are manufactured in China, which are then shipped to India to be used in the manufacturing of finished drugs, which are then shipped all over the world, allocated by wholesalers and distributors, and then onto pharmacies. Now, also many brand name drugs, including commonly used HIV medications, are also dependent on complex global manufacturing and supply chains. So, really in short of it is that we cannot discount the risk of disruptions due to COVID-19. So while manufacturing in China is now coming back online, the potential for COVID-19 to impact generic manufacturing in India remains an important threat. And while many brand name manufacturers are currently reporting adequate stocks, brand name prescription drugs are still dependent on distributors, pharmacies, and many workers vulnerable to COVID-19. I will just say that the US Food and Drug Administration is closely monitoring supply chains, notably manufacturing shortages, and there is information on the FDA website about its COVID-19 activities to protect prescription drug supply chains in the United States. And NASTAD is one of several organizations keeping a close eye on the potential and actual risks of prescription drug shortages and disruptions that can impact our community. Next slide, please. So, to fully support COVID-19 quarantine and social distancing requirements and to help minimize the need for treatment interruptions, the HHS interim guidance that Dr. Hardy just walked us through recommends that people living with HIV have at least 30-day supplies, ideally a 90-day supply of antiretroviral drugs and other medications on hand. So, the good news is that many public and private insurers, we're talking Medicaid, Medicare, AIDS drug assistance programs, and commercial insurers, have relaxed their refill and their quantity limit policies to allow for early refills and 60 or 90-day fills. And I also want to note that the Coronavirus Aid, Relief, and Economic Security Act that was passed earlier today includes a requirement that Medicare Part D plans and Medicare Advantage plans must provide 90-day fills to beneficiaries who request them. Now, I will note, however, that not all insurers or plans have relaxed their refill and quantity limit policies and are not allowing early refill or 60 or 90-day refill overrides. Still, other insurers are requiring beneficiaries to use their mail order pharmacy if they want 90-day fills, which may not necessarily be ideal for some people living with HIV. Next slide, please. Okay, so how is the US supply chain looking for people living with HIV, and by extension, people using antiretrovirals for pre-exposure prophylaxis, or PrEP? So NASTAD has been in close contact with all of the major manufacturers of the most commonly used HIV treatment and PrEP regimens, and all are reporting adequate production and stocks to meet projected needs. Some very good news for now. But one thing to note is that many wholesalers, and these are the entities that purchase prescription drugs from manufacturers and then sell them to pharmacies and other direct purchasers, have implemented fair share allocation processes. And these are actually put into place to prevent stockpiling of a medication, to ensure that all pharmacies receive a minimum of 100% of their usual shipments, and by extension help guarantee that customers are able to keep purchasing their medications without any interruptions. Now, as a result of these, some pharmacies may be unable to secure the additional inventory they need to meet the increased demand for 90-day supplies. And pharmacies, what I will say there is that pharmacies can contact the wholesaler to request an exception to the allocation limits. And it's also worth noting that many pharmacies are rising to the occasion and strengthening some of their capacity to do mail order options, home delivery options, including the use of couriers, and also providing hours for people most vulnerable to COVID-19 to shop in a controlled and mostly sterile environment. So I'm going to stop there, turn this over to Emily to talk about some of the work that our HIV programs are doing within state health departments.
Thank you, Tim. Next slide, please. So as many of you know, the Ryan White HIV/AIDS program is administered, Part B and ADAPs are administered through state health departments. Although this is very different than a natural disaster, many state health departments already have existing disaster plans to ensure that people can ensure access to medications during times of disruption. Some ways that they are doing that right now, and they're also developing further policies so that people can be served during quarantine requirements and social distancing efforts. So we're looking at early refill and dispensing limit overrides, which is a lot of what Tim just talked about, streamlined recertification and annual renewals, network exceptions, telehealth and phone consults with case managers. And although the Families First Act did pass quite a bit of coverage of COVID-19 testing, the Ryan White HIV/AIDS program Part B can cover that if it is not covered for any reason without any cost sharing. Next slide. Another place that health departments have really been stepping up is around drug user health and syringe service programs. While in some places the syringe service programs have been deemed essential, unfortunately they have closed in at least 2 states, and we know that they're essential to helping to prevent HIV. So health departments have been working to ensure that SSPs are designated as essential services, providing emergency funding for additional harm reduction supplies, exploring delivery and mail-based provision of supplies and virtual service where it's feasible, looking at mobile, peer, and outreach-based distribution efforts, removing restrictive policies that limit syringes participants can acquire. For example, in some places, a one-for-one exchange is required, and that is not helpful right now, because if you can only receive as many syringes as you turn in, then you can't sort of plan for the social distancing and quarantine. And they're also looking at just different containment and safety protocols for syringe service program staff. Next slide. Another place that I think both health departments and just sort of people overall are exploring is temporary housing for SSCP participants and people who use drugs. We know that a lot of shelters do have sobriety requirements, so exploring where people can actually stay when they are needing to self-quarantine. Looking at washing facilities in areas that experience a high volume of public drug use or homelessness. A distribution of hand sanitizer, antibacterial wipes, and soap through harm reduction programs. And then encouraging shelters to allow for stability of beds for residents to minimize contact with pathogens, and then working with states and local medication assistance providers and state behavioral health agencies to ensure access to 14 to 28 days of take-home medication-assisted therapy. SAMHSA did just release some regulation or loosen regulations around this, so we are excited to see that moving forward. Next slide. NASTAD has a website of sort of COVID-19 updates and resources where we are updating almost every day on ARV and prescription drug supply issues, different things that the Ryan White program is consideration, any HRSA guidance. I will also say HRSA just published an FAQ that's really helpful, different drug user health resources, resources for incarcerated individuals, and then the legislative and regulatory responses. Next slide. Turn it back over to you all.
Thank you so much, Emily and Tim, for that. We know that this is a lot of information, and what we will ask is if people can just submit their questions in the chat box. We're going to have a Q&A at the end, but if you can just submit your questions in the chat box, we catalog your questions, and then we can ask those questions again towards the end of the presentation. Thank you. Next, we have Dr. Darrin Johnson from BU Wellness Network.
Great afternoon, everybody. And thank you to Jay Maurice and Andrea for having me as part of this talk. So BU Wellness Network is a community-based organization in Indianapolis, Indiana, providing services to people living with HIV, and particularly Black, gay, and bisexual men and Black transgender women. Therefore, we have deemed all of our services as essential services during this pandemic. Next slide. So our agency is often the first line of health communication for our communities. And we receive questions from community members about COVID-19, how this impacts our services, and daily media reports and the increasing cases of coronavirus. I have communicated with BU Wellness Network staff members about updates and reports from our local and state departments of health, and how it is essential for us to communicate recommended guidelines from these entities, such as our local and state departments of health. We've communicated the importance to our clients of telephone and virtual visits for routine and non-urgent visits as a method of safety, and that community engagement activities like support groups cannot happen at this time. Also, we've communicated that personal, physical, social interaction should be limited. This communication from our agency, from people the community knows and have consistent interactions with, has reduced some level of fear concerning COVID-19. Many of our programs are social and supportive services. So with partial and full agency closure, these services have moved to telephone or virtual interactions. However, our goal is to maintain as many services as possible while we support our clients during this time. Whereas typically telehealth for our agency and community partners is usually for medical related services, we have modified our social and supportive services to a telehealth format, which is a shift for our frontline staff who primarily provide in-person supportive services. Next slide. We are reminding our community members that maintaining social distancing does not mean we have a total agency shutdown. We want to maintain virtual social interactions while practicing physical distancing. Maintaining our community presence means that we are utilizing social media to the best of our ability. We're communicating with clients via messenger apps for information and to make appointments. And we have daily phone conversation with our clients as well. We have restricted walk-in services, but will allow appointment-only access to services like our food pantry, as we are aware that stores have limits on purchasing items, and challenges to healthy food access have been exacerbated by these limits. In addition, documents that usually require client signatures in person have been modified for better electronic access to prevent office visits. And these changes have been communicated with our funding agencies and other essential community partnering organizations. Next slide. For employee safety, we have developed a pandemic safety plan, or also called a widespread illness plan, which as a small community-based organization, we haven't necessarily needed to use. So it's really been interesting rolling this out and launching it and having to use it. And I also reminded employees to reinforce universal precautions and other safety policies. I also reinforce or introduce guidelines for teleworking to ensure and maintain HIPAA compliance. Also, internal communication is extremely important as staff are not working in close proximity like they would if they were in the office. I continue to provide updates from local and state health departments as necessary to our employees. Also, included in our pandemic plan, or our widespread illness plan, is preparation from myself as the executive director and our administrative team about how to effectively telework, what tools are needed, recommendations and guidelines on personal and business travel, updates on our partial and full office closure and procedures around that, and also maintaining professional expectations while teleworking and communicating with clients, as again, some of our staff members have not, teleworking was not their primary way of communicating with clients. Thank you.
Thank you, Darrin. And next up, we have Scott from Lambda Legal.
Hi, everyone. Good to be with you today. And I want to say thank you to HRC for putting this together and giving us all the opportunity to speak to the community about these issues. So I'm going to talk a little bit about the legal rights of people living with HIV, as well as the communities most impacted by HIV and the COVID pandemic today. Next slide. So first, I just wanted to acknowledge that, that discrimination happens against our communities, and we know this as members of these communities, that this discrimination is real, and that it could potentially affect people's access to care. There are two cases that we are currently working on at Lambda Legal that address this issue very directly. One is the County of Santa Clara versus HHS. In that case, when the administration put out its new rules that would allow for people to deny care to individuals based on the personal religious beliefs of the provider, we filed a lawsuit to try to stop those rules from going into effect. And in fact, we were successful in that lawsuit. I wanted to mention that some of our community providers were plaintiffs in that lawsuit, such as Whitman Walker Health, the LA LGBT Center, the Center on Halsted here in Chicago, and a number of others, because they would be potentially dramatically impacted by these rules. And fortunately, we got a preliminary injunction blocking those rules from going into effect. And then an actual injunction and ruling from a court in California that blocked implementation of those rules, and that's now on appeal to the Ninth Circuit Court of Appeals. Another case that actually we just filed this past week involves another move by the administration to attempt to no longer enforce the protections that are in place that prevent grantees, federal grantees, from denying care to people based on things like their sexual orientation or their gender identity. And the administration is attempting to change that rule. And in the meantime, before they even changed the rule, they issued a notice that they would no longer be enforcing that rule against the federal grantees. So we are moving to actually to have invalidated their declaration of non-enforcement. So these are just a couple of examples. I'm sorry I didn't say the name of that second case. That's Family Equality versus Azar. And some of the plaintiffs there are also community partners we're all familiar with, such as SAGE and others. And these are just a couple of examples of ways in which we know that discrimination happens, and that this administration in particular is engaging in activities to make that discrimination more possible. So with that in mind, next slide, we wanted to make people aware that there are resources out there from Lambda Legal. If you should run across any type of discrimination that is based on your HIV status, your gender identity, your sexual orientation, that you can reach out to Lambda Legal's help desk. We're very interested in hearing about any of these things that are going on in the middle of this pandemic. While we are all hopeful that a crisis like this would perhaps focus people on the needs of the patients before them, and to get them to set such petty things aside as their personal beliefs about someone else's sexual orientation or gender identity, we know that that doesn't always happen. So we're ready, we're here. I've got the website up there right now. It's www.lambdalegal.org/helpdesk. And that is the page where you can complete a form that will go right to our help desk attorneys for evaluation, or there are also numbers that you can call if you want to speak to someone. Next slide, please. So I also wanted to talk a little bit about legal documents that people really should already have in place. We should all have in place, and I'm going to just raise my hand and say I'm sort of the number one. I'm guilty of this, the lawyer without a will. But do as I say and not as I do. We should all have be thinking about and have these things in place. And then when something like this arises, where there's a serious threat to people's health that could come on suddenly and that would be unexpected, it is good to be thinking about these things. So we have listed here a living will, which is something to think about. It's an advanced directive laying out what kind of healthcare you want, how you want those sort of decisions to be made in the event that you are incapacitated and unable to make those decisions for yourself. And it is very helpful to have those types of things laid out in a document, making clear to your loved ones and those who will be making those decisions for you what those are. Along with that, a medical power of attorney, so that you're giving someone else the power very clearly to make those healthcare decisions in accordance with your wishes. And along with that, it is wise to have a HIPAA release so that it is ensured that that person making those decisions will have easy access to all of the information that they need from your medical records to help make those decisions. Another thing to think about is a financial power of attorney. So if for some reason you are incapacitated, again, it is helpful to have someone who has been empowered to handle financial arrangements and decisions while you are incapacitated in that way. And you have to think in some ways about other people that depend on you, children, etc. So good to have someone else that can step in and potentially assist and take over responsibility for those dependents in that situation. There are additional things here, a revocable living trust. These are different ways to handle, and then the will, different ways to handle end of life sort of decisions. And I think it's interesting that I was unaware of this really until putting this presentation together, but that it's wise to include a digital assets memorandum that actually allows people access to your emails and other digital information so that it's clear who you want to have access to that and how you want that to be handled. And then the other things listed here, life insurance, organ donor designation, and then how you would want your bodily human remains to be disposed of. All things that, of course, we never want to think about just in general, which is why I think a lot of people avoid these issues, but very, very useful and helpful to have in place. I don't know how the life insurance market is being affected by this. So I don't know how easy it would be to get life insurance in this context at this time, but it's something that people should be thinking about all the time for themselves and their loved ones as they move through life. So that's all I had for right now, and I look forward to taking people's questions.
Thank you so much, Scott, and thank you to all the panelists for their wonderful presentations. There are a couple of questions in the queue. The first question, it was a hand raise actually from Jennifer, so I'm going to take Jennifer off of mute so she can ask her question. Jennifer? Hello? Okay, so we will move on to the next question. And this question was for David. So what about things that cannot be handled via telehealth, such as blood draws? Should I continue to get my blood drawn for routine monitoring?
You know what has been discussed, and they actually go into a bit of this in the DHHS interim guidance, is that if your viral load has been undetectable and you've been continuing to take your medications on a regular basis, and your T cell count is still been high, say over 400 or 500, then it is probably just fine and okay to postpone the drawing of your routine blood test, because during this period of time, as long as your medication is continuing to be given to you on a regular basis and you've been able to take it, there's really no reason to think that the medication would stop working. So it's probably safe to put off those routine blood drawing tests until it's actually more safe to go into your physician's or your clinic's office.
That's very helpful, David. So I have another question for you. With social distancing the mantra, and we hope everyone is heeding that call, what about sex?
Yeah. You know, I heard something very interesting just recently about how the Department of Health and Mental Hygiene in New York City is handling this. And they're basically saying that because this infection is spread through droplets, meaning that if someone coughs, sneezes, or accidentally spits, the virus can actually be found in those secretions. Because of that, and also the fact it's been documented to be found in feces and stool, it's a pretty good assumption, although I haven't seen any scientific data on it yet, that the virus would also be found in sexual secretions, in semen, and probably in cervical secretions and vaginal secretions. So at this point, exposure to those secretions is very easy during any kind of sexual activity. So what I know the New York City Department of Health is saying is mutual masturbation is the safest way to go, because unless you know the person who you're having sex with has been tested and is COVID test negative for the virus, there is a risk that persons who do have no symptoms from the virus, from COVID-19, the COVID-19 virus, that they can transmit the virus to someone else very easily. And having sex which almost always includes some sort of transfer of bodily secretions from one person to the other, could very easily do that. So it's a situation in which just because someone is not ill, does not feel ill, does not have a fever, that does not mean that they don't have the virus and could not transmit it. So I think that's something to keep in mind when we are making those choices about sexual activity.
Thank
You're
you.
saying we need to have sex from 6 feet away, David.
That's pretty much the story, Scott. And be careful with mutual masturbation, because that could actually end up being transmissible.
Yeah.
That's very helpful. Thank you. I have another question for Dr. Johnson. And first, let me just say thank you so much to you and your staff who are meeting the needs of community members and taking care of your clients during this incredibly challenging time. And how are your staff managing the fear that is coming from their community members and the clients concerning COVID-19?
Let me text him because he probably is on mute. We can go to the next question.
Okay, so I will, this one is for Schoettes. So I am an attorney by training, and I know that a number of these documents that you outlined require notarization. And how do you deal with that in this current environment? Yes, how do you handle that in this environment? And where would you find some of these forms?
So those are both great questions. I'll handle the second one first because it's the easier one. You know, a lot of these forms are available online. I know one organization that does, that provides these forms in terms of advanced directives and that kind of thing is 5wishes.org. There are other places that, you know, you can find a form for a will in your state, a will that's valid in your state. As people probably know, the rules around wills and what makes it a valid will vary from state to state. So it's important to have a form that is applicable to your particular state. I'm not going to provide the names of any for-profit entities on here right now, but people can Google and find probably both resources that are free as well as some that charge in order to help to assist you in putting together a will in your state. In most places, you know, the basics, if you have a very basic will, it is not that difficult to do. And then turning to the first question, which is harder, I'll first say that some states do not require something like a will to be notarized. It has to be witnessed sometimes, but not necessarily notarized, and sometimes has to be witnessed by more than one people. All of those things should be clear on whatever form you might be using. But in cases where a notary is required, I'd actually reached out to the notary in our office, and hopefully maybe just received an email helping me to answer this question, but there are some states that do allow for notarization without, basically from home. And maybe I'll come back after I've hopefully read this email from the paralegal in my office to provide more information on that.
No, that'd be great. And maybe that's information we can share after the fact.
Great.
And so I see Dr. Johnson is back. So if it's okay, I'll go back to the question that we teed up for you just a few minutes ago. How are the staff members in your organization managing the fear that is coming from their community members and clients concerning COVID-19?
Okay, thank you for the question. So first, we maintain our communication with clients, and we remain available for quick responses for any questions or concerns that they may have. Also, we're transparent about the concerns that we have as staff members and what we're doing to maintain safety both individually and as an agency. And then lastly, we reinforce guidelines from our local and state health departments so that, you know, they are ensured that we are giving official information and that we're giving the correct information as we receive updates about what's happening with this pandemic.
Thank you. We have a question from Matthew Rose, and he wants to know what plan is there for additional outreach to those that have fallen out of care?
So we have all staff working. So essentially we have sort of collapsed our org chart, and we're all working together to make sure that you know, anyone is able and willing to communicate with staff. We are being visible on social media. We are all taking calls. We are all making referrals. So we're just working together to make sure that you know, any questions, concerns, and comments and people do not fall through the gaps, and also to maintain the level of services that we would provide if we were working in the office. So you know, there has been some challenges in getting to this place, but I think if we continue to effectively communicate with each other, that would be my recommendation for other organizations, is to is to just try to get everybody on the same page and, communicating with clients. Whereas, for example, a linkage care person would be the ones, linking folks to care. But our program coordinators who monitor and implement our prevention programs, myself, my program director, case managers, counseling and testing staff, we're all working together to make sure that clients are connected to whatever service they need.
Great. And there was a second question that was pretty much posed to everyone. I'm trying to find that question. Sorry, I just lost place. So what are the best practices around viral suppression and COVID messaging? And I guess that's posed to like everyone, to all the panelists.
So this is something, this is Scott, and this is something that I've been focused on because I do think that it's an area in which we need to be nuanced in our messaging. And the messaging is not one size fits all. And I think it creates some hazards for us when we sort of address it as if one size fits all. So there is a difference in the risk, and maybe Dr. Hardy will speak to this sort of from the medical side in more detail. But my understanding is that what really matters most is, in this case, the CD4 count. So viral suppression obviously helps people get to a higher CD4 count, but in terms of your immune function, what really matters is, are you in a place where you have a normal number of CD4 cells? And I do think it's important that we not overly create any more anxiety than necessary for people who do not have a compromised immune system, while ensuring that we are sending a message that everyone needs to engage in these precautions, and that people who have a lower CD4 count may be at a higher risk and should definitely be engaging in every precaution. But Dr. Hardy, did you want to add to that?
I think what you said it was very helpful, Scott. I think, one of the things that has really been emphasized by the HIV treatment community is that the most important thing that probably protects people from having complications of HIV is having not only a high CD4 cell count, but a undetectable viral load. Certain studies have even shown that as long as someone's viral load is undetectable, they can still sometimes have lower T cells and not have opportunistic infections. Just suppressing the virus seems to be a very powerful way to keep people in a safer situation. So certainly making sure that medication supply is very, very solid and continuous, and reaching out if it looks like that there's going to be a problem with getting your medications in some way early, so those problems can be solved as quickly as possible. There's ways that pharmacies will deliver the medications to your house if you do not want to leave the home for some reason, or you're self-quarantining. And so just really making sure that you're not missing your meds is a really important part of all this to keep yourself safe. Keeping that viral load undetectable is a very important part of keeping oneself healthy during this period of time.
Got you. Thank you so much for that. So we have a question for Tim. The person says, I get my medication at the local pharmacy in 30-day increments because that's the only way to secure copay assistance from the manufacturer. Do you know if manufacturers will make copay assistance available for 90-day refill requests through mail order pharmacies?
Thank you for that question. First, I think I would be remiss if I didn't send a special shout out, not only to our doctors and nurses, but also the pharmacists and the pharmacy staff, many of whom are potentially putting their own health at risk to ensure that we all have access to the medications we need and are likely under considerable stress. The one thing I'll say there is that that the pharmacists do have the ability to apply copay assistance cards or coupons to 90-day supplies. and that this is something that can be readily discussed with pharmacists. Now, in the event of challenges, even on the pharmacy end, many manufacturer copay assistance programs do allow for copay payment receipts to be submitted to the program for reimbursement. And in this case, what I would do is suggest a quick call to the copay assistance program to get the necessary sufficient guidance in terms of how to submit those receipts.
Thank you. And then we have a question from Julia. Can NASTAD or anyone else share which states shut down SSPs and as non-essential services?
Yep, so we're still waiting to confirm which states have not deemed them essential and are trying to reverse the decision. I'm going to confirm and provide an update since it's sort of changing. It feels like minute by minute.
Thank you.
I wanted to jump back in real quick to let people know that I've got some information on the notarization piece. So for instance, Illinois actually has a online notarization bill in effect until our governor rescinds his emergency order. So the states have thought, some states at least have thought about this, and you may have such an order in place in your state. And then there are there are platforms online. There's a platform called notarize.com that helps facilitate online notarization. So those are two resources I wanted people to be aware of.
That's wonderful. Thanks, Scott. So this, I think, is probably for Emily and Tim. We're hearing, obviously, watching the news from the hospitals and healthcare facilities across the country about the lack of access to PPE, masks, the gowns. Are any of these shortages having an impact on our Ryan White clinics? And then if they are, what is it impacting their ability to take care of their clients?
Yeah, and I think that the Ryan White clinics are slowly but surely just trying to figure out their own standard operation procedures here. I think that with the shortages of PPE, that may inhibit the ability of some of our Ryan White providers, including some of the FQHCs that are Ryan White grantees. Unless they are able to access PPEs, unless they are able to, secure, safe clinic spaces to be seen individuals who suspect they might have COVID-19 or that they are experiencing symptoms of COVID-19. I think there is the potential for Ryan Whites to really have to decide how, in fact, they can approach this, given the limitations in PPE, or even the limited staff capacity or like infrastructure capacity to see patients and clients who suspect that they may have COVID-19.
That's very helpful. And then this question is probably, again, maybe more to you and Emily and Scott. I know that the Congress has now passed 3 packages, COVID in response to the COVID pandemic, and they have various resources and to respond to help clinics, and I know that there was funding for the Ryan White program. There was additional funding for HIVMA. At this point, are there things that may have been missing in those bills that we need to go back to Congress and ask for? Because I anticipate there will be a 4th package. And I realize you may need to get back to us because that bill was pretty big the other night, but I just thought I'd throw that out.
Yeah, I think that we are working really closely with health departments to see where gaps remain. There was $4.3 billion in that bill for CDC, but most of that is understandably going towards respiratory infections. But places that we are excited that there's also going to be funding is in the data modernization. We do think that there's a lot of opportunities, especially when we're thinking about the experience that STD prevention has with cluster detection or contract tracing. We know that many health department employees across all departments are focusing almost exclusively on COVID right now. So helping build up that public health infrastructure is definitely something we'll be looking at. So we're working really closely with our members to see sort of where the gaps are. I also know that, as we sort of are able to scale up testing beyond just what is happening in sort of hospitals right now, if there's enough PPE, we could think about how our clinics just serve populations that don't touch the medical system in other places. So, that goes beyond just health departments, but I think that we're going to have to sort of see how, if PPE is accessible and how testing increases in accessibility.
That's great. Thanks, Emily.
We have a question from Octavio, and the question is, a major concern during this crisis is mental health and emotional support needs for people living with HIV and/or AIDS. Are there any contingency plans addressing these needs? I'm afraid that the issues related to medication adherence and viral load control are going to be present as a result of the neglect of mental and emotional health.
Am I unmuted?
Go ahead. Go ahead, Darrin.
So a couple of things that we are doing in our agency. Our mental health therapist is also working virtually. So she's doing telehealth counseling sessions. But we also are maintaining our support groups virtually as well. So, our clients can still have the peer-to-peer support and, and engagement while we are not with each other. So again, we are maintaining our support groups virtually. They can also talk to staff members and individually, but we also are maintaining our mental health counseling appointments as well.
Thank you.
This is David Hart. I just want to congratulate Octavio for making that point, because I think one of the worst things that's oftentimes happening to all of us is that feeling of isolation and not being able to get the human contact that we're so used to, which can be very devastating in many ways, especially for those who might be having problems with depression. So, I think what Darrin just said is very important. One has to start learning to be more electronically creative in terms of connecting with the people who you normally connect with. No one's saying that you can't call them up, create a Zoom account like was created for this webinar with your friends in the same city, and maintain those connections, organize those connections, and really make sure that you're reaching out to people because they need you as much as you need them. I think that's a really important part of all of this, particularly when persons may feel like they are in a situation where other people don't understand, and I think that could be a common feeling among persons living with HIV who have felt that before.
Thank you so much. We have a question from Jennifer, and Jennifer wanted to know, would you happen to know if there are any ongoing RCTs on the treatment of COVID-19 that include people living with HIV?
When I went on to the clinicaltrials.gov website, and there were 86 different clinical trials that were either ongoing and recruiting. A couple have actually already been fully recruited, those in China primarily, or planned for the future. I did not see in most of them that being HIV positive was an exclusion factor, at least listed on the website. Now, in this situation where everyone is susceptible to this virus, irregardless of always what other kind of medical problems they may have preceding, I can't see that would necessarily be a reason to not allow someone into a clinical trial. And in fact, it may be, if someone does have immune deficiency related to HIV, could be actually a good reason to do it. So I think that is something that is probably happening. I don't think anyone's being excluded because of their HIV at this point, but that may be a case-by-case basis based upon the clinical trial as well.
Appreciate it.
Thank you very much for that. So a question we have from Bill. We are hearing about instances of criminalization of people with COVID. I know Italy is potentially imposing up to a 5-year sentence against people with COVID who leave quarantine. This somewhat mirrors HIV criminalization issues, although of course the disease is more easily spread through the air. Any guidance on this? And also, We are trying to move people out of prison and other correctional facilities, especially the elderly and those with underlying conditions with HIV. Any thoughts about this issue as well?
So this one feels like it kind of falls to me. Again, I think I'm going to answer the second question first because it's a little bit easier. I mean, I think that those efforts to get people out of situations where they are being unnecessarily or are being placed at a much greater risk, you know, these situations involving incarceration are all wise. And in particularly, I know that there's an effort here in Illinois to get people who are in pretrial detention, who often are there simply because they couldn't make bail, and where there's already been a determination that the person is not a threat to the community. I know that there are efforts underway to have all of those folks released during this time of the pandemic. So all of those efforts, I think, are wise and make sense to the extent that we can get people away from the highest risk situations, which are as we know, any congregations of essentially more than 2 people at this point. On the issue of HIV criminalization, I think it's a really tough one, and it's one that we, you know, we have struggled with some in reforming laws across the country. For instance, in California, the folks there in the public health department were reluctant to give up some of their ability to restrict people's activities in the event of an outbreak like this, or to threaten people with that kind of sanction. I think that it is probably more often used, at least for something like this, as a threat than actual prosecution, but it's still there, and it is worrisome of what kind of precedents it could set. There are also ways to distinguish the situations, as kind of mentioned in the question, in terms of how different things are transmitted, and a degree, I would say even more important, of consent. So, you know, as we know, it takes 2 to tango when it comes to sexual transmission and transmission of HIV. Whereas if someone with COVID has chosen to get on an airplane, those other folks weren't sort of consenting to the additional risk of having someone with a highly transmissible respiratory infection on board that airplane. So there are ways in which these situations are distinguishable, but we also are concerned about any precedents that may be set or the ways these laws might be used in this time of panic and fear. Heightened anxieties tend to create activities that perhaps aren't the wisest in the long run.
Thank you. Andrew, did we have time for 2 more questions? Andrew, did you want to ask your question and then I'll close it out?
Sure. This question is for Dr. Johnson. What advice do you have for CBOs that offer social and support programs to people living with HIV and who are dealing with the additional pandemic as well?
Thank you for the question. So I think I talked about this a little or mentioned it already, but moving as many services as you can, or maintaining your as many services as you can virtually is extremely helpful, particularly support groups and prevention programs. You know, those things can be creative and fun online, but you know, just making sure that you have constant communication with your community members and your clients during this time is extremely helpful to let them know that, you know, you're still operating, that services are still available. You know, because in many cases, you know, some of our clients might not have other options. So, you know, we just try to be as available as we can and continue to maintain our services and then, keep that constant communication virtually.
Great, thank you so much.
And in closing, I'll pose this question to everyone, all of the panelists. What's one thing, we talked about a lot today, but what's that one thing you want to leave with everyone?
So this is Darrin. I know, so these are interesting times. It poses challenges for, I'm sure all of us on the panel and, those on the call, all of our organizations. But, the thing we want to do is just to make sure that we don't perpetuate fear. We continue to follow guidance, and we stay connected. We share ideas, and we share communication with each other so that we can make sure that folks do not fall through gaps, and make sure that the most vulnerable populations are not going without services. So that would be my takeaway or advice.
Great, Darrin. This is David Hardy. I would just say, to really echo Darrin's comments, is that we learned a heck of a lot about discrimination and stigma through the HIV epidemic that started almost 40 years ago. And to be able to apply those learnings now to what's going on with COVID is very important. We do know how this virus is transmitted, and we do know how we can protect ourselves, and we must stick to that knowledge of doing it in order for this to pass, because it will pass. Unlike HIV, this is not a chronic infection. It does not last a lifetime. It is short term, but it's much higher risk in terms of death. So as long as we follow the advice of our medical and scientific experts and stay safe, it will pass, and it will become something that hopefully will never come back again, or at least will be vaccinated against it. So I think that's really important to keep in mind, is that there is light at the end of the tunnel, but we all must really stick together to make sure that we are being aware of the recommendations that are very scientifically based in order for us to get through this.
So I'll jump in, and I would say I really appreciate the question about mental health. And my one thing would be, let's make sure we're paying attention to all those mental health needs of the people who are living with HIV and are perhaps, well, everyone's feeling anxiety right now. And then I think we should work to ensure that the issues that come up for people living with HIV that are particular are addressed, and that we are nuanced in our messaging so that we're trying to tamp down those fears where they are unwarranted. So yes, that would be my overall message. Let's pay attention to the mental health effects of our messaging.
I guess the only thing I will add, thinking about healthcare access and prescription drug access, that we are an engaged community. We are an empowered community. We are a community of advocates, and that this is now a time to make sure that our voices are heard. If you are experiencing challenges receiving the care that you need, you are having challenges experiencing getting the medications that you need, you must make your voices heard. Make sure that you're working closely with your pharmacist, for example, to understand why you might be having challenges, getting 60 or 90-day supplies, why there are challenges getting early refills, and even more importantly, if you're at risk of actually seeing a treatment interruption as a result of stockouts. Work with your pharmacist, work with your insurance companies, work with your providers, and in turn, your providers can work with organizations like the HIV Medicines Association, whereas health departments can work with organizations like NASTAD. We are a coalition of advocates who can and will continue to make things happen when there is injustice, particularly in healthcare access.
Great. And I wanted to say thank you to Dr. Hardy, Tim, Emily, Dr. Johnson, and Scott. This has been very informative information that you provided us today. And for that, we are thankful. There were a couple of questions in the queue that we weren't able to get to, but what we will do is be able to provide you a response to those questions within a couple of hours. I'll have them for you by the morning. And then also, this presentation will be made available via video. It's being recorded, but then we will also be able to provide you the slides as well. Andrea, did you have anything else you want to add before we close out?
No, I just want to thank our panel again for making themselves available on such short notice. Obviously, this is a very urgent issue that we need to get information out to our community, and thank you again for helping us do that today.
So thank you, and everyone have a good day and be safe.
Thank you. Thanks, everyone.
Thank you.